Good to be with you all today, and thank you for taking some time out of your Friday. I know everybody, especially in the healthcare industry, has a lot on their plate right now, and just the response to COVID-19 and how it's impacting each of your communities. We continue to hear stories of the different impacts, whether you're in the front lines providing care services, working through issues with supply chain, readying for ICU bed capacity limitations, and all the other providers too that are impacted now today, and having concerns about just the significant impacts to elective procedures and the financial impacts on their organizations. So for today's session, we did try to solicit questions in advance of this, and we did receive actually hundreds of questions. So we had a chance to try to sort through a number of those and build those really into some broad discussion areas. Today we're going to touch on a variety of items related to cost reporting concerns. We'll get into revenue cycle and telehealth, just with the significant amount of focus there on different changes and relaxed rules or differences with telehealth type services. Again, everybody's experiencing operational type impacts and human resource considerations with this. And then finally circle back and spend some time on tax-related matters, as well as some of the current legislative activity that's out there between the Families First Act and the CARES Act that we're hoping soon will be passed. So with that today, just some quick introductions for the team that's on the phone. You have myself, who's a partner in charge of healthcare services for Eide Bailly. I have Kim Hundredson from our National Tax Office with us. Joy Krush, a senior manager with our revenue cycle team and healthcare consulting. Dion Sukle in the revenue cycle healthcare consulting world. Brian Birch, who is a principal in our healthcare consulting area and specific to reimbursement services. Mel Schwartz will be joining us later. He's doubled up today on two different sessions, but he'll join us later to discuss specifically some of the legislative activity. And then Jackie Colt, certified healthcare business consultant, senior manager in our healthcare consulting practice, who works specifically heavily with medical practices. So glad that they could join us, and we're going to get right into the questions here. Today, the first one specific to rural health clinic. We have a rural health clinic with low volumes due to COVID-19. Will there be an exemption to rural health clinic productivity standards as a result of this? So I'm going to turn it over to Brian to tackle this question.
Well, hello, everybody. This is Brian Birch with Eide Bailly. And in regards to this question, we have not heard anything from either CMS or the MACs as of yet if there would be an exemption to the RHC productivity standards. I've heard from a number of clinics, RHCs during this time, that the volumes are down and concerned that they may not meet the RHC productivity standards, which if you're an RHC would know that this could impact your reimbursement and the all-inclusive rate that you would get at cost report settlement time. So we have not heard as of yet as to whether or not they would do anything. I know the associations of rural health clinics have posed this question. Also, the thing that I would say here is that if you do not have practitioners that are currently, due to the low volumes, if you have reduced also your practitioners, whether that be mid-levels or the physicians' time in the clinic, that make sure that you're noting that for the counting of the FTEs and the RHC. We'll see what CMS indicates to that, but I would recommend that we, if the practitioners aren't available to see patients in the RHC during this time, also that we would not count that time towards your productivity standard.
Sticking with RHCs, in this case, question was raised, PPS hospital with less than 50 beds that has a provider-based RHC or multiple, and they must add beds due to the COVID-19 situation. Will they continue to be exempt from the RHC cost per visit limitation if they have to expand that bed capacity?
Yeah, wow. So some interesting questions here that all have to do with the rules and regulations that CMS puts out there. And so this one, if you're a PPS hospital and you have less than 50 beds, you're not hit by or subject to the cost per visit cap, which is around $84. And so with that, if you increase your beds above that, typically you would be subject to that cap, which would limit payments and hereby reduce your payment. I would say this in regards to this, that if you're over that 50 beds for a period of time due to COVID-19, I would document, how long you're there. I don't believe, our hope is that this would not last a significant amount of time, but that during this period you would not be, I'm not saying for sure on this one, but would indicate how long you were over that 50 bed capacity to then indicate to CMS that, hey, it was for this period of time. It was not for our whole fiscal year, and therefore, we shouldn't be hit by that. They're subject to the cost per visit limitation. There's also another piece that you could exempt yourself under that's out there under the rules. So if you're a PPS hospital, and even if you're over the 50 beds, if you had an average daily census of less than 40 for acute care services and you are in a level 9 or 10 rural urban commuting area, you could still qualify for this. So if you would meet that one, then we really wouldn't have to document it either, but that's again an exception request to CMS. So yeah, nothing officially that CMS has put on this, but hopefully that you would be over that 50 beds in a short amount of time.
Yeah, and we'll certainly continue to see details unfold with some of these items, and certainly hope that we'll get some more clarification, as things unfold. Moving into the cost reporting topic, how should we account for costs due to COVID-19 for cost reporting purposes?
Yeah, well, and we're getting lots of questions in regards to this. Kind of twofold, and I don't know, Jeff, there was another one that talked about it separately in regards to FEMA or potential grant opportunities. But our recommendation is that you continue to code any expenses to the departments that are revenue producing departments, just as you have before, for cost reporting purposes, meaning matching up with expenses and revenues. If you had additional costs over and above this, such as supplies, things like that, you could do one of two things. What we see some facilities doing and recommend is kind of best approach is if you're possible and you want to do it through your GL, to set up within each department COVID GL accounts that you could potentially track wages to, and supplies and equipment, rental costs for equipment, et cetera. Some facilities have looked at a COVID department also for any of those additional costs because of this, and putting it into a COVID department. My recommendation is, if you do that for the cost report, is please keep track of what those expenses were that were going to the COVID department, what they were for, what department. Because for cost reporting purposes, we will most likely have to turn around and recode those expenses back to their departments. That includes wages, supplies, et cetera.
There certainly are some questions with that coming up, Brian, just in connection to as we look at maybe possible funding sources from different federal programs, whether it be FEMA or HRSA or others. So within that, there'll be additional guidance coming out specific to those programs, but it's an area too where most of those programs where you're getting cost type reimbursement from the government in some fashion, a key thing to keep in mind is somehow it needs to be traceable back to the accounting records. So you need to have some level of support that you can work back into the accounting records. It can be in subledgers or detailed support. Doesn't necessarily need to be at the general ledger level, but keep that in mind too as it relates to this. Question on several people's minds as well this week has been, will there be an extension of any of the due dates for Medicare cost report filings that might be coming up here over the coming months? Brian, can you speak to that also?
Yeah, yep. Well, there's been a lot of information out there, and there's been a number of Medicare administrative contractors that have put stuff on their websites. I don't believe anything official has been came out from CMS, meaning there's been no transmittal or anything giving the extension, but a number of MACs, as I have indicated, have said that there is an extension for specific year ends. And so, we haven't put out anything to until I hear something more from CMS is what we've kind of been waiting for. But here's what we're hearing is that if you had a fiscal year end of October 31st of 2019, your cost report would be due next Tuesday, which is March 31st. Those have been looked to appear to be extended until June 30th. If you were a November year end, your cost report was normally due at the end of April, April 30th. Those appear to be extended until June 30th also. And if you're December 31st, 2019 fiscal year end, your cost report was due May 31st. Those appear to be extended until July 31st of 2020. I caution you with this, that's what we have now is what we're hearing. A lot of facilities have also talked about hearing about cash flow, et cetera, and we'll talk about that in a little bit. I strongly suggest looking at potentially, if you fall into that cost report extension timeline, to still get your cost report filed, especially if Medicare would owe you money on that. That's a way for you to get some cash back from them. So maybe not consider using up that full extension of time frame in order to get your cash coming in the door. If you owe them back, hey, you can sure hold it just like we would a tax return or something, and wait to file it on the extended date. So.
Okay, thanks, Brian. We are seeing some Zoom webinar chat comments and different questions coming in the Q&A as well. Feel free to keep sending those out there. We'll grab a few of those maybe as we go. We do, like I said, have a lot of questions that were already submitted and prepared for today. So we do anticipate some follow-up communications just related to today's webinar that will come out as well. Moving back to an RHC related topic, we're an RHC, and we heard part of the upcoming stimulus bill, we'd be able to provide telehealth visits, and how would we get paid for these? So a few questions coming up related to this, Brian, but maybe can you take an initial stab at this one, and we'll spend some more time on telehealth coming up.
Yeah, I'm probably going to let Dion spend most of the time addressing this one coming up. I know that's there too, or if she wants to chime in here. In regards to how would you get paid for these, so RHCs typically could not be a distant site provider, meaning the practitioners within the RHC could not provide telehealth services. And so my understanding is that part of the CARES Act that has not yet passed, so you cannot yet provide these services as a distance an RHC, but it is included in the CARES Act. And I'll let Dion speak to how you'll get paid, but my understanding is it's not through the all-inclusive rate for RHCs. And since it won't be through the all-inclusive rate, it more than likely means some type of fee schedule that you would get paid. And therefore, those costs, what I want to make sure is on the cost report that you understand that if you are going to provide these services as an RHC practitioner, that the facilities capture the cost, the time that the practitioners are spending providing telehealth as an RHC practitioner, because you will need to carve out those costs from your cost report at the end of the year. Again, these costs won't be part of your calculation of the all-inclusive rate, so you'll need to make sure that you're getting that time, that compensation carved out from your RHC costs.
All right.
Thanks,
Brian. Lots of fun for accounting departments. So, yeah, we'll spend a little bit more time on telehealth coming up. I think cash flow is on everybody's mind, Brian, not just for critical access hospitals, but we did have several CAHs just have general questions in regards to cash flows. What can we do to improve cash flow now?
Yeah, so this question has been out there quite a bit, and I'd love to have magic answers for you. So two things. So hopefully I can give you some thoughts that might help. Number one, if you think you're owed money as a critical access hospital right now, if you're doing an interim cost report or anything like that, or could potentially do an interim cost report to send into Medicare to get a lump sum adjustment and get your rates adjusted. I recommend doing that. Or if you're on a model that estimates where you're at throughout your fiscal year, recommend updating that model. If it shows that you're owed money to Medicare, get that into Medicare right away and get your rates adjusted. So that's one way to do that. As I mentioned before, with the cost report extensions, if you're 1231, make sure you get that cost report done, and if you're owed money, get that submitted right away too, and get that money from Medicare. Again, all this is going to take a little bit of time because Medicare has to process that information. As part of the CARES Act, again, which is not yet passed, one option out there too is the option for accelerated payments, and what that is the old PIP methodology, periodic interim payments. Again, this is not yet passed. It hasn't passed the House yet, and the President has to sign it into law. But that they're opening that up to critical access hospitals, children's hospitals, cancer hospitals, which is normally just eligible for your PPS hospitals. And what that would mean is you could request to get payments early from Medicare based on what your payments were, for instance, in your last fiscal year. And so they'll do either biweekly payments or could do a lump sum, irregardless of your claims that you're submitting, and just have a steady stream of cash coming into you. So that will be an option if the CARES Act approves. There's another one that's out there. And I know that there's others in regards to loans and SBA loans and stuff like that could be an option potentially too.
And we'll also speak to some of the pieces on SBA loans coming up, Brian. So we'll get in a little bit more detail on what that piece is looking like. To circle back just on the telehealth topic, many impacts through the different forms of relief related to just expansion or simplification of telehealth. Circle this one over to you, Jackie. Can you speak just to how facilities can go about getting telehealth visits reimbursed and provide some insights to some of the changing rules there?
I know some of our questions asked, what's telehealth, what's telemedicine? So let me start out with that. Telehealth refers to the collection and the electronic and the telecommunications, so more of the IT part of, communicating with patients. And that includes phones, Skype, video conferences, etc. It's more of the technology side. Telemedicine is more of the treatment side. So telemedicine is the practice of medicine using these technologies. So there is a distinction in between the words there. So telehealth and telemedicine, as you know, has been expanded. All gloves off by the mandate from President Trump, that lifts pre-authorizations to, who can provide telemedicine and where. I think we'll go into some of those specifics, Joy and Dion. Well, one thing that when we actually, CMS is still requiring that if you, the doctor, are providing the services out of your home, you still need to put that designation in there. If you go to your office, then that's fine. Your office is probably already registered with Medicare. But if you are doing it at home, you do need to notify Medicare of your home address. Just make sure that you're doing that. When we look at, loading our systems with all the information for telehealth and telemedicine, providers are saying, well, what do I price it at? And we're looking at anywhere from 180% of Medicare to 225% of Medicare, which is an easy number to help you load your system so that you can start billing for the service. We'll get into the specific modifiers, et cetera, place of service shortly. But as far as loading your system to be able to provide these services, that's the range we're seeing. Many providers out there, including rural health, have a percentage of gross charge. So if you have further questions on that to maximize your reimbursement, please reach back out to us and we'll help you.
Thanks, Jackie. just more along those lines, as we get into, the next handful of questions that have come in are specific to telemedicine, billing and coding. Maybe anything to add on that as we start to hear different questions on those topics.
I think Kim and Dion will be addressing these here shortly.
All right. Joy, I think a handful of questions here that we've accumulated are specific to that. First and foremost, what are the billing and documentation requirements for telehealth visits while a patient is in their home?
Yeah, thank you, Jeff, and hello, everybody. So under the 1135 waiver, we know telemedicine visits now can be performed while the patient is physically in their home. To determine what services that we can perform, we refer back to every year Medicare publishes a list of services that can be performed via telehealth. You can also refer to the CPT book, Appendix P also lists those services. So these visits can be conducted, as Jackie alluded to, via FaceTime, Skype, Zoom we're hearing being used. The one thing I want to caution you, as CMS has indicated, what is not allowed would be, public facing type mediums such as Facebook Live, TikTok, those types of things. One thing I want to make sure, that we kind of remind providers, we're still reporting an E&M service. So even though the patient's at home, the documentation requirements don't go away. And we know that our physical exams probably are not going to be that detailed. We don't have the patient in front of us. But we want to make sure that those other parts of our note do support the visit. The other thing to keep in mind is these visits, may not lend themselves to the higher level E&M codes. However, I do want to make one comment here. If counseling and coordination were to take a big part of that visit, that may help you then assign an E&M service. So one of the recommendations we would definitely have is in your note, document start and stop time. That way we've got the time, at the end when we're trying to assign E&M codes to this, we'll have that to be able to support those services and get it paid appropriately. And then just one other thing, with the telehealth visits while the patient's at home, there will be no originating site because the patient is at their home.
Okay, thanks, Joy. Second question along the lines of telemedicine, how can I use virtual visits and e-visits?
Yeah, what's interesting about these codes is that this really isn't under the waiver. These codes became effective January 2020, and so they were pretty new. We haven't really used them a lot yet, so everybody's kind of looking at is this a way to help provide services to our patients? For the virtual visits, Medicare has some specific HCPCS codes. They have G2012 and 2010, G2010. The G2010, the only thing I'll say is that's kind of a store and forward. You could, the patient could take a video, forward it to the provider gets back to him within 24 hours. What we're hearing more out there is that what's occurring is a lot of patients are calling in, they're having a conversation with the nurse, kind of getting a triage, and they're trying to decide, should I come in, should I stay home? The nurses can offer then a virtual visit with that provider, and then the provider can have, for example, a phone conversation with that patient, and they can make the decision, no, stay home, treat with this, etc. The one thing about the virtual visit is there's some rules behind it. So this can't be used if I had a visit with a provider and now the provider calls up and follows up with the patient. That's not a virtual visit. Or if during that virtual visit the provider said, no, I think you need to come in and see, come into the office and see me, then we can't report it. But what it really is useful for is if we have a conversation and we're not going to bring that patient into the clinic, we just have a telephone conversation. Lots of questions about, patient consent. Again, if the nurse is having that conversation and offers this to the patient and that's documented, that would seem to meet the intent of patient consent. The e-visits, those seem to be more kind of the, again, non-face-to-face visits with the patient that are initiated through the patient portal. That seems to be more geared towards the patient portal, and that's the 99421 to 423 category. One thing too that you want to make sure of is, we're talking heavily about what Medicare covers today. For example, the virtual visits, the G code. What are the commercial payers using? Maybe they're using the CPT codes in the 994 category. We're going to have to check with each of our major payers to understand that, and even if those payers will cover it. I had a conversation with a payer this week that said they weren't covering the virtual visits yet, and that was the word they said to me, yet this may change. So just those things to keep in mind. And then for the rural health clinic, there is one virtual visit code, G0071. It reads similar to the G2012. So that is available for the rural health clinics. And then again, with documentation on these, we want to make sure the method of the visit, we had a telephone call with the patient. We talked about the patient consent already. And then these are timed codes. So again, that start and stop time is very important.
Joy, with that, I have a question. If we had a virtual visit with the patient, we decide that they need to come in, we can only bill one E&M to Medicare. So would you add the virtual visit time to the E&M when the patient came in?
I am going to say yes, that you would include that in that visit. Yes, that's a good question, Jackie. Yeah.
Thank you.
All right, thanks. Continuing on the path here, what place of service or modifiers are necessary to apply with this billing activity?
Yeah, so for billing on the 1500, the place of service is going to be in O2. The other thing is there is a modifier 95, and we are seeing some of the commercial payers saying they will require that 95, so that's important to keep in mind. If I am billing a method 2, so I'm billing my professional services on the UB, then I need to apply the modifier GT. One thing I've learned in the last 2 weeks as we've had a lot of providers call with questions and talk through scenarios, we really have to understand, what our billing is. Are we billing on a 1500? Are we billing provider based? Are we billing provider based method 2? Those things are just always so important to make sure we understand when we're making sure we're going to bill these appropriately, because what we don't want to do is bill them wrong and get them all back. We want to try to get them out the door correctly the first time.
Absolutely. Thanks, Joy. Throw this one at Dion. Several states now have Medicaid waivers for COVID-19. Do I have to apply for an individual 1135 waiver?
Yeah, so at this point, because it is kind of blanket nationally from a CMS standpoint, so under Medicare, there is really nothing that you have to apply for, because it's just what we're doing across the nation at this time. But you do want to be sure that you're putting on, as Joy was saying, your modifiers, your condition codes to indicate when you're treating patients specifically for the COVID-19, but it isn't anything that has to be applied for. In the past, maybe like if there was an 1135 waiver due to a hurricane or something like that, when clients are Googling the 1135 waiver, they may see some indication that you have to register, but in this case, it isn't necessary. But having said that, there may be individual state requirements that have to be met. So because it isn't blanket for all Medicaids at this time, although every day we see more and more Medicaids that are accepting it, that we would suggest that you contact your state or monitor very closely your state and your expansion plans if you have Medicaid expansion, to know if that has to happen. And we're going to follow these instructions until it's revoked, when we start thinking about how things are changing during this time period. And typically these 1135 waivers, we see them terminate no later than when the end of the emergency period is, or 60 days. That may expand. There's no way at this point for us to know how long will we operate under these rules, but just be aware that as soon as this does expire or terminate, that we will go back to the rules that were prior to that.
Looking forward to maybe getting back to normal,
Yeah.
certainly, Dion. So with back to RHCs, FQHCs, what are some of the most current updates and thoughts there related to telehealth services? There have been a lot of questions related to that submitted ahead, and a few chat questions as well.
Yeah, so we're really in unique times. As Brian indicated, up to this point, RHCs and FQHCs were not able to bill telehealth because there's always been that overarching requirement that you can't bill anything unless there's a face-to-face visit with the patient, between the provider and the patient. What we do know is that what we are waiting for basically to get passed and the president's signature is that RHCs and FQHCs will be able to bill telehealth. I am monitoring the National Association of Rural Health Clinics. They're really kind of our main source that goes through and kind of helps the rural health clinics to kind of navigate through all of this and know what the billing rules and regulations are, what it means to that community. And so the indication is that it's going to be handled much the same as chronic care management. As Brian said, it will not be reimbursed at the all-inclusive rate. And that, you know, what we don't know today, and we have to wait. Once this is signed, then we have to wait for CMS to tell us these are the rules. So if it follows chronic care management, it'll go on your UB, it'll, you know, but it'll be paid at fee schedule. So as Brian indicated, we're going to have to then carve those expenses out. So I think that's something that we, you know, really should prepare for, that there is no indication that it will be the all-inclusive rate.
Okay, thanks for that, Dion. Changing directions a little bit here. I'm going to go back to Jackie on this one. I mean, we're hearing a whole variety of providers that just the business as usual has been displaced, which is causing practices and other providers to just look at human resource related issues that are out there. So first one here relating to benefits. How can I assure the continuation of health and dental benefits? Jackie, if you want to tackle that one.
Well, that's been a big challenge. When most of the dental practices were forced to shut down, many had to lay off their employees. You know, each individual policy that we have for health and dental within any healthcare industry or any business, if you will, each healthcare entity plan has guidelines. And so I highly recommend getting with your agent or your plan administrator and understanding, can I continue? If you have the resources, we've laid the employees off, we still want to cover that, but am I forced to go on COBRA? Am I forced to have them go on COBRA for the next couple of weeks, maybe a month? I would work really closely with the plan administrators or your agent to determine, you know, the best avenue for your entity. They're the ones that are going to dictate that. Typically, when we lay people off, the plan requires you to immediately put them on COBRA. So if there's any kind of adjustment there, they're making any exceptions, I would just work with them and see what exceptions there are. If we're planning on, you know, rehiring them in 3 weeks, you know, each plan has given practices different answers. So they'd prefer to put on COBRA, or some of them are waiving that and holding the benefits for 3 weeks, and then they'll make another decision. So please get with your agents.
Okay, thanks for those thoughts and certainly compliance considerations there. Also, just kind of in the cash flow planning, a lot of business disruption. How are people handling just staff, wages, and vendors, during these periods where they're either shut down or running, skeleton capacity with just a few emergency type procedures and what they're able to still do? Can you give some thoughts on that as well, Jackie?
Yeah, some of the providers have enough resources to clean up the facility. They've completely overhauled the facility. They've utilized staff in different ways. The billing crews are still trying to collect payments and claims. They've really revved up the revenue cycle area and put more manpower. Some practices have kind of downscaled. Maybe they didn't have the reserves, so they've laid off, just created a skeleton crew, if you will, to answer patient calls, help them, do telemedicine. As far as, vendors, many providers that own their own buildings are able to, adjust payment for rent, et cetera. Other ones that don't own their own buildings are asking for holidays for payments, calling their bank and seeing if they can extend their loan payments, going to other bigger vendors and seeing if they could have another 30 to 60 days to pay. So they're getting very creative, but we do have some providers that didn't have the resources and have had to lay off everyone and shut down for the interim. So we have it from one gamut to the other. It's more about your particular resources that you have and your ability to hold the practice in current state.
All right, thanks, Jackie. The next question, and this one is relatively broad, and certainly the market's getting inundated with thoughts and ideas and speculation, but maybe just if you can share some of your thoughts on what financial help will be available for different types of healthcare providers, medical practices, and beyond.
Well, good question. There are, once the bill passes through, we'll have the employee retention credit, and we'll get more information and details on that. The other one is the business loan program, where we can take out a loan to help, with ramping back up and covering costs until we start, start seeing patients. There's also the emergency economic disaster relief loan. It looks like that some of the costs may be forgiven. So that's another avenue. So currently now there's that, from what we see on the medical professional side, there's probably going to be about 3 different avenues to help facilitate and get through the financial burdens.
I've gotten a couple of texts, and panelists just posted too that the House just did pass the CARES Act bill. So that's at least one less hurdle. That's at least what I'm hearing coming through my phone that's going off, and what's on the news. So
thanks to Liz Story, who's listening in, for throwing that in the Zoom chat as well. So one more question, circling back to just, the handling of employees, and we'll get into some more details on this, obviously. But Jackie, what policies, from a policy standpoint, are healthcare organizations using for employee leave, whether it's sickness for themselves, family-related sicknesses, daycare-related issues, all the kind of disruption we're facing now, school closures? If you can share on that.
Yeah, any practice or entity that has 50 or fewer are exempt from FMLA, exempt from the Families First Response Act, et cetera. So it's more of, what can you viably do for your employees? If your policy for the smaller practices has that, sick leave is not granted when you're laid off, you have to, kind of follow your policies there. Some providers are making exceptions Some policies within your organization may have that they get to have their sick leave, PTO, vacation, and they can use that. That's on an individual basis. Above 50 and beyond, FMLA takes in effect, and if the act is passed, then the Department of Labor currently has employee rights, and there are several provisions that you have to follow, as far as paying sick leave, paying portions of their wage up to a certain amount. And we can, distribute the exact requirements to you out so that you have it directly from the Department of Labor.
Okay, thanks, Jackie. I believe Mel has joined us from another firm-wide webinar that he's been involved with, getting into a little bit more detail on the Families First Act, and Jackie spoke a little bit to the FMLA requirements. But Mel, if you're able to hear us and join us, if you can explain just in a little bit more detail the FMLA requirements and the credits under the Family First Act. And thanks for being with us.
Sure thing. I trust I'm coming through.
Yep, sounds great.
There are two major pieces in the Families First Act. One is, and all of this, let me say at the beginning, applies if you have less than 500 employees, and we can get into the detail of how you count employees a little bit later, but just to look at the basics. If you have less than 500 employees, then you are required to provide 10 days of mandatory paid sick leave for an employee that's subject to a quarantine, is subject to an isolation order, or has been advised by a healthcare provider to self-quarantine, or for that matter, has been showing symptoms and is in contact with the doctor. Doesn't mean I'm going to be in contact with the doctor a week from now. It actually has to be getting in contact with the doctor. Now, in addition to that requirement, also paid sick leave has to be provided to anyone who is taking care of that kind of person, or who is home caring for a son or daughter under the age of 18 whose school has been closed, whose place of child care has been closed, or is no longer has access to their normal child care as a result of the coronavirus precautions. This all applies if the employee, because of one of those factors, is unable to work or to telework. If they can telework, then you're not required to make this payment. To the extent that you do make one of these required payments, and let me say, the second piece here, that's the required medical leave. There is also a ability to, or a requirement that you provide paid family leave for someone who needs to take care of someone who is sick with the coronavirus, or if, again, for someone who cannot work or telework because they are providing care for a child, their child, under the age of 18, whose school's been closed, whose daycare has been closed, or for whatever other reason related to the coronavirus, their normal child care is no longer available. This is called, we've been calling this the grandmother. Grandma has been taking care of the kids, and grandma's doctor says, you can't take care of the kids anymore. You need to go lock yourself in your room. Then the parent, not the grandparent, but the parent, if they are your employee and you're covered by this, would be eligible to require you to pay them this expanded medical leave. Now, these payments, sick payments, have to be made primarily at the rate that the employee normally would receive, subject to a maximum of $511 a day. If you're talking about leave, whether it's sick leave or this expanded family leave for taking care of someone who's sick or taking care of a child, then the rate per day declines to either $200 a day, or again, the normal rate that they would pay if we're under that 10 days of sick leave, or 2/3 of the normal rate if they are under the expanded family leave. Now, I think do I have control here? I think we have some, oh, I'm sorry, we also wanted to know about the credits. To the extent that you incur cost, you as an employer incur costs as a result of the Families First Act, that is eligible to be refunded as a credit, really in full. So the amount of wages that you pay, the amount of Medicare taxes from your employer share, plus the proportionate share of whatever health care costs you're incurring on behalf of your employee for that rateable period of time, all are eligible to be refunded. Now, the refund first comes against any Social Security tax that you are required to deposit on April 30th. April 30th is the next quarterly due date. If the amount of credit you are entitled to exceeds that amount, then the IRS is supposed to provide you with a check. Now, when we get into the CARES Act, which just, as we noted, just passed the House and presumably is going to be signed by the President tonight, there's going to be a deferral of the deposit of those employment taxes. So in light of that, I think what we're really looking at is the credit will be affected in the form of a check from the Internal Revenue Service. The Internal Revenue Service, we know, is working on a form. We don't know when the form is going to be out. We hope soon. And we hope that they will be set up to deposit your money relatively quickly. And but we will have to wait. There's no question you are making an advance to your employee if you are providing a mandatory leave under the Families First Act, but it's intended that you be fully compensated for that going forward. Very good. Do we want to look some more at the
There's some additional questions, Mel, just that were raised, all tied to Families First. Anything further to add related to sick leave?
Well, I think that really the requirement there is you've got to be in the right category with regard to the number of employees you have, and the sick leave has got to be for one of the stated reasons. The employee's sick. The employee's been told to go isolate. The employee thinks they may be sick and is in contact with the doctor. Do they have to tell you do they have to tell you in advance? The answer to that seems no. However, after the first day, you can require them to at least inform you that they now meet the circumstances that would require the sick leave, or for that matter, the extended family leave to be provided.
Now, this is Jackie. I do not believe that that we have to have a test and report that to our employers. I don't think that is a requirement, correct?
They have not stated what the requirements are going to be. I think that the initial informal indications is no, you don't need a doctor's note. You don't need anything specific. The indication that we have received from speaking to people at the IRS who are ultimately going to be in charge of providing these credits are saying that they pretty much expect the employer to be able to rely on what the employee tells them. And that seems to be a similar sentiment over at the Department of Labor, who will be in charge of the question, do you need to provide it? And then the recompense moves over to the Internal Revenue Service. Given the fact that this is all going to come into place very, very quickly, it's difficult to believe that they are going to require anything in the way of significant backup. Although, as is always the case, you want to make sure you have some kind of record in your file that indicates what you did and why you did it in case somebody asks later on.
I know that doctors in the country, at least in a couple of states, said, please don't have your employees come and require a letter from us. We're overwhelmed, we're inundated. So they were asking employers to waive the physician note to come back to work, physician note to extend your leave. So just want to put that out there.
I think that's consistent. We will need to hear that as an official word, but all indications are they're moving in the direction of accepting that. And certainly it's hard to believe that contemporaneous records would need to be provided. And that if they do later require something, it might be something we could backfill with.
Thanks, Mel. With all of this change, coming out in short order, and things change on a daily, hourly, by the minute basis. We've had a lot of questions from folks that may have already furloughed or done some type of staff adjustment, directed them to file unemployment. Is it too late for them to pursue the sick leave?
Yeah, if they're not your employee, and keep in mind, the Family First Act is not effective until 1st of April, which I guess is what, next Wednesday? So if they are already furloughed and they're already gone to unemployment, then they're not your employee, and they're not part of the count to the 500 or to the 50, I think we're going to get into in a minute, nor are they eligible for this. If you were to rehire them, then they would automatically become eligible for the sick leave. And assuming they had previously worked for you for at least 30 days, would be eligible for the extended family leave. The question, I think, as to whether you want to do that or not is going to be heavily dependent upon what unemployment compensation really looks like over the next month. Both the pieces of legislation, the Families First Act plus the CARES Act, that is on its way to the president now, have some significant improvements, including really a $600 per month cash top-off for unemployment comp. And so depending upon what your staff was being paid, where they fit into the things, it may be that it's to their advantage simply to stay off, and for you to rehire them somewhat later in time. Also, keep in mind the fact that you furloughed them for your business reasons does not qualify them for the mandatory sick leave, the mandatory care, because they have to not be able to work, not be able to telework. And for one of those designated reasons, the fact that you may be shutting down in the meantime is not really the controlling factor for providing the sick leave or the expanded family leave under the rules. Ultimately, that may be expanded. The House Democrats are talking about an expansion to cover a situation where an employee is furloughed for that reason. But right now, there's another provision in the CARES Act that may be of benefit, but the furloughed employee is not an employee and does not get the immediate access to the sick leave that you would normally, that they might otherwise get.
Another question coming up just related to our healthcare organizations. Are there any exceptions to these requirements with the Families First Act for our healthcare providers?
Yes, there are for healthcare providers, not for healthcare organizations. Healthcare organization is still subject to the rules, but an employer can exclude a healthcare provider or an emergency responder from any of the requirements that, excuse me, they can exclude them from the any of the requirements really at their election. And this was intended to discourage people from allowing their healthcare providers to take advantage of these provisions and to keep them, frankly, on the job. The definition of a healthcare provider is going to be in the hands of the Labor Department. They have not published any guidance. If we look back at prior guidance, the general rule seems to be if you are licensed as some kind of medical professional by your state, then you fit under the definition of a healthcare provider. If you are simply a trained person but not licensed, it seems doubtful that you will meet the definition, at least as we can currently see it, of a healthcare provider. And certainly if you're talking about someone who does essentially clerical work for a healthcare organization, if for whatever reason they're not able to work or telework, then you cannot exclude them from the Families First benefits.
Thank you for that information. We are coming up close to the hour here, but we do have a handful of additional questions that we're going to work through. So certainly understand if folks have to jump off and get back to other duties, but we'll keep plowing ahead here. Mel, staying with you, how do I determine the number of employees for application of the Families First Act?
Well, essentially you count them, and part-time counts as one, full-time counts as one. If you've got a situation where, for instance, maybe your clerical staff is leased from someone else, or for that matter, even some of your professional staff is leased from someone else, even if that someone else is responsible for payroll, is responsible for health benefits, if that person is normally working at your facility, is normally working for you, they count as your employee. Now, and we've gotten a ton of questions on this, and this is something that we desperately need some better guidance from DOL on. And we hope we will see it soon, but we don't have it yet. So all we can really do is sort of find our best way through here. The other issue here is whether or not different organizations, different entities need to be combined. If you're talking about a situation where there is 100% identical control, 100% identical ownership, those entities almost certainly are going to have to be pulled together to determine whether you are within the 500 employee limit or under the 50 employee limit. Remember, if you've got more than 500 employees, Families First doesn't apply to you. And consequently, you are not eligible for the credit to refund the money. If you do, you don't have to provide the sick leave, but if you do, it's on you if you're above the 500 limit. There's also a 50 employee limit that we need to be able to determine the number of employees for. And if you have less than 50 employees, then you can apply to the Department of Labor to be excluded from the requirement that you provide either sick leave or extended family leave for your employees, if that is going to essentially threaten the entity as a going concern. How do you prove that? Well, we're not quite sure yet because the DOL has not told us, but the advice that we're getting, at least on an informal basis, is write down why you believe requiring you to pay sick leave or extended family leave would threaten the business as an ongoing business, and put it someplace safe. Don't send it to us now because we're not ready to receive it. And maybe we will see some better standards in the future. But that is the essentially the number of employees for the how you determine that.
Perfect. Changing path here a little bit to the SBA side of things, Mel. What types of entities are eligible for the loans under the SBA program? And can you just shed a little more detail on what that SBA loan programs or multiple different loan programs look like?
Well, there are a number of existing SBA programs, which many, I think, healthcare organizations are eligible to apply for. I would focus on the new program that is included in the CARES Act, which is very noteworthy because it includes the ability to have your loan forgiven. In addition to some other benefits, the interest rate can't be more than 4%. You can get $10,000 out of it very quickly, even before your loan is formally approved. In order to qualify for that new Small Business Administration loan, again, you have to be less than 500 employees, and you have to essentially promise that you're going to use the proceeds of the loan for payroll, to continue health care benefits, to pay rent, to pay a mortgage, or for that matter, to pay the pay the interest due on pre-existing debt. You can't just pay down pre-existing debt with it. And then the second key here is that if you the amount that you can borrow is 2.5 times your monthly payroll, or 10 million bucks, whichever is less. If you can show that you spent the money for the right things, which is essentially everything we talked about you're promising, other than paying off prior debt. You can show that you spent the money for those things, and you have not reduced your payroll, you have not reduced the number of employees, you have not cut anybody's pay by more than, I think it's 20%. Then the entirety of your loan can be forgiven. If, for instance, you do not meet all those standards, then only a part of the loan can be forgiven. But as long as you still have some employees and have not zeroed out anybody's pay, at least some of the loan should ultimately be forgiven. Now, that's not, people I think have talked about that in terms of a grant. In many ways, it is effectively the same as a grant, but it is really a formal loan with a formal forgiveness provision. If you're for profit, the forgiveness of the debt will not be treated as taxable income, but you don't have to be a for-profit entity to apply for one of these loans. Nonprofit entities can apply for the loans. For that matter, solo practitioners can apply for these loans. If you're a doctor or a dentist working on your own, you can apply for your own loan under these circumstances.
So Mel,
you probably don't get the whole 10 million, but that's something that's available.
Does that mean I have a lot of doctors asking, does that include my wage? If they have a guaranteed payment, or we have a set, wage that we're paying them, does that include that in the number?
If they are an S corporation and they are receiving a wage, then to the extent they are treating that as a wage, yes, they can use that and they can apply for a loan on that basis. With a caveat that we will need further guidance. To the extent that you're playing the old game of only paying you a wage to get you to the Social Security limit, and the rest is self-employment income, I begin to be a little concerned about that. Similarly, a guaranteed payment in a partnership is not technically a wage because you can't be an employee of your partnership. How that will be handled is up in the air, I think, at this point, but there is a possibility that ultimately will be eligible. And I think that's one of the things that I know the firm is putting together a team that will specifically focus on this new opportunity with the Small Business Administration. And I know that that is one of the issues that they're very much focused on.
All right, thanks, Mel. We're getting a lot of good questions coming in related to things, and again, we don't have multiple hours to probably spend to this today, but we're certainly going to dovetail and take a lot of the questions that are coming in and either getting out written guidance on these or following this up with additional Zoom meetings or different things where we can share on this. So keep the questions coming, and you can expect us to respond to them over time. So changing directions here a little bit, and we got the good news that the House got the job done on the CARES Act. Mel, what financial incentives are out there with that applying to healthcare entities specifically that you can share on?
Well, the tax provisions that specifically provide incentives to retain your employees all will be available to healthcare entities. There are also a number of direct payment and direct funding that really are a little bit beyond my scope of coverage. There certainly is specific money focused on funding up the healthcare's response to the coronavirus situation. But I think I will have to leave that to those who are dig into more of those issues to provide some detail on, and that may be something that would be a good subject for follow-up.
Jeff, I just would add,
yeah, go ahead, Brian.
Could add maybe a little bit from some of the other items that come out. So one of the provisions was that Medicare was going to suspend the 2% Medicare sequestration effective for payments from May 1st to December 31st of this year. So would see a bump up in payments under the Medicare program for that, so suspending sequestration. However, they would tack on an additional year of sequestration. It was supposed to end 2029 federal fiscal year. It would end federal fiscal year 2030 then. For the PPS payments, if you treated anybody with COVID as an inpatient, you'd receive a 20% bump on your DRG for that payment, also suspending and further delaying some scheduled cuts under Medicaid DISH that were supposed to go into effect in May to the end of November. So some items in there that would help prolong some scheduled cuts or incentive payments that would affect some of the healthcare entities that are out there too.
All right, thanks for adding that. That is a topic that you can expect some additional information to come out on. I know state hospital associations, the American Hospital Association, among others, have been monitoring that closely. So pay attention to anything state specific that might be relevant to Medicaid, but we'll also be getting out additional information as time progresses with those programs. Maybe just to wrap it up, as we're hearing about tax return filing extensions, et cetera. Kim, any more recent news as it relates to different tax return filing deadlines and extensions specific to healthcare providers?
Yeah, thanks, Jeff. So I think most people are aware that the individual income tax returns were extended from an April 15th to a July 15th deadline. That also includes the requirement to make your tax payments for the 2019 tax returns and first quarter estimated payments. If you're required to make estimated payments, those were extended from April 15th to July 15th. The second quarter estimated payments, which are due June 15th, are actually still due June 15th at this point. So you'd actually have to make your second quarter payments before your first quarter payments, which probably is subject to having some change made to it, but at this point, that's where we currently stand. Those extensions also apply to other types of tax returns, primarily corporate tax returns and trust returns that were also due on April 15th. That April 15th date is a really important one because that's the only due date at this point that the IRS has indicated they will make the extension for tax returns. So I know we have a lot of nonprofit organizations who have their 990s due May 15th. There has been no extension provided for those tax returns. We also have some organizations that had 990s that were due April 15th. They did not extend the 990s at all at April 15th. So there was an extension for 990Ts if you had a taxable return, but that extension does not apply to information returns. There has been a lot of pushback by the AICPA and other organizations indicating that that extension should apply to the May 15th deadline, that the information that's needed for those tax returns are pretty significant. And given everything that hospitals have going on, that nonprofits have going on right now, and trying to just address the issues and being on the front lines, we should get an extension of time for the returns. I think we'll wait and see what's happening, but at this point, we are moving forward with the idea that everything due May 15th will continue to be due May 15th.
Hate to have you get too much of a break, Kim, on those 990s. So
I know, exactly.
That gets us to the end of what we had accumulated for different questions. I see a handful of questions in the Zoom webinar chat. I think the Eide Bailly representatives probably at least have a few minutes here to continue to stick with us. We will do a recording of this session, and like I said, we're accumulating all of the questions that came in, and we'll try to respond as we can to some additional questions. But just to ask maybe a few follow-ups that I'm seeing here across the side. There's that whole question related to Family First Act and healthcare provider exceptions. There was a question, Mel, related to whether RNs, LPNs, certified nursing assistants, others that might be licensed under lab, radiology, PTO, TST, the different therapy services. Any thoughts as to that, or maybe can you just give us some thoughts there?
The expectation, I think, or as my understanding is that the expectation is that if you were licensed by the state in a medical field, then you would meet the definition of a healthcare provider for the purposes of this, and you could be excluded from the right to receive either paid sick leave or paid family leave. Again, some of this is really based upon prior decisions over by the Department of Labor, and so we're kind of reading between the lines on this. But in talking with people who really spend significant portions of their life with this type of issue, they seem to believe that this is the best interpretation we have now. If you've got a state license, then you are in a medical field, then you are probably a medical provider, and that includes not just traditional medicine. Well, that's a difficult word to use because I have no idea what non-traditional medicine, how that is going to fit into this. But certainly psychology, psychiatry, those are areas that, again, if you're in possession of a license, we believe that would be included in the definition of a healthcare provider.
Okay. With the SBA loans, Mel, are there any limitations that you're aware of for types of entities that might not qualify? Question specifically related to like a government district hospital.
I believe that a
government related affiliate.
I believe a government district hospital, so long as it is not set up as a division of the government itself. So in other words, it has a separate charter, it has, all of the things that, make it a, quote, semi-governmental entity. clearly would be eligible for the small business loan if they meet the other standards. So my guess would be that a governmental hospital would normally be organized in such a form that they could apply for one of these loans. I will note that there are already so many people trying to apply for the loans that it's very difficult to get through on either the phone line or through the internet. But keep trying, because it's something that we have to a certain extent the rebate for, or the refund through a credit for the sick leave and extended family leave that you provide, and the Small Business Association loan, and then there's another provision that it's a credit for employee retention. And that one is key because you don't have to meet the under 500 employee standard for that one. The three of those, to a certain extent, interact, and you may need to choose between the three. So it's something that I think that you want to take a look at how they work in each of them works in your particular situation. It's not something that you would just automatically say, oh, well, I want a loan, or I want to claim this credit.
Yep. No, that's good. That's good guidance. Brian, I'm going to throw one at you. I think there's a lot of questions with different grants and loans, but there's a question raised regarding if we get an SBA loan and we meet the forgiveness provisions, what happens on the cost report? Not to put you on the spot, because I'm guessing the answer is as gray as we expect it to be, but what are your thoughts on that situation?
Yeah, well, that definitely gray. There's no black or white there. It is technically written as a loan, from what I read in the CARES Act, but treated like a grant. So I'm really going to have CMS's interpretation on this, or the MAC's interpretation. Grants in the Medicare regs and the Program Manual 15.1 are not used to reduce operating costs. So if it was treated as a grant, would not have to offset that against costs on the cost report. However, because it is a loan, we'll see what the MACs have to say. The conservative route is it would be used to reduce any operating costs on the cost report currently. But again, waiting to see where all this plays out. So yeah, that's a pretty gray one right there.
Okay. Another reimbursement-driven question. Somebody with a surgeon who is displaced due to the, limitation elective procedures. Any thoughts on tasks or concepts for cross-utilizing that surgeon for different types of reimbursable areas, administrative functions, et cetera?
I'm sure Brian has. Brian, you probably have some, but I've had hospitals actually, work with either employed or non-employed to help, triage, help in, like the ER, critical care on the floor. Have you seen that type of transfer of their resources too?
I have, not only with physicians and mid-level practitioners, but even staff amongst various departments doing that. In regards to this one, if you're not, transferring their duties to another department that's patient care related, and because you no longer have, elective procedures and your surgeries are down. In regards, I'm assuming this is coming from a critical access hospital, what I suspect, because they're saying, okay, what could I do to make this, a portion of their comp allowable now? What I would be looking at there is you're going to have to do a time study during this period in order to ensure that you're capturing that time that they're spent doing administrative functions, reviewing your operating room policies, procedures, quality control, things like that would really, be an administrative function. that's the things that I could think of off the top of my head that would, capture a portion of that as an administrative function and be allowable on your cost report.
Okay. And then I think we'll just hold this to maybe the last question for the day. For those that can speak to the telemedicine, telehealth, there's a question: can we bill for just a phone call as telehealth, or does it need to be via Skype or some type of video service? So I don't know, Joy or Dion, if you want to tackle that one.
Yeah.
Go ahead. I'll start, Dion, and then you finish.
Okay.
So if we're going to do a telemedicine visit, we need to have a visual of the patient. And again, think about that we're billing, we're going to bill an E&M, so we've got to do all those components of that visit. So that virtual visit that we talked about, now again, those are definitely less reimbursed, but that would be what would kind of lend it to just having a phone conversation with the patient. Would you agree, Dion or Jackie? Yep. Any comments?
Yeah, definitely. And like you had said, there are some payers that are paying codes because there are CPT codes for that. Under Medicare, we have G codes that are used for that, and specifically in the RHC, it's a combination of the G codes, and you would bill out that G0071. But that's the secret to it, I think, is if you're going to bill it as telemedicine, there has to be some kind of interaction between the patient and the provider.
Visual, yeah.
Well, thank you everyone very much for today. You'll see in the last couple slides here the full contact information for those that participated from Eide Bailly today are included here. So we will review questions that we did not have a chance to get to that came up during the course of the Zoom meeting, and we'll send some information out along with the slides, and I believe, Ellie, a link to the recording would also be included with that. So again, thank you for everything you and your organizations are doing, certainly thinking of you from a provider standpoint and how you're impacting our communities in a positive way related to this pandemic. So have a great rest of your Friday and a great weekend, and let's all get through this together. Thank you.